We had a great discussion in our rapid fire debates at EAU discussing kind of the different approaches for patients with high risk features post cystectomy or with a positive kind of pelvic recurrence after cystectomy based on conventional imaging. And these are challenging scenarios to deal with. And our current standard of care for many patients is based on Checkmate 274. A lot of these patients are receiving adjuvant nivolumab. However, emerging data is coming out showing the benefit of more radiation therapy in these patients. I think to some of the prior randomized studies from Zagul et al. In the Egyptian cohort showing a potential local recurrence-free survival benefit for patients receiving post-cystectomy or adjuvant radiation with high-risk features. We also had the published data from ASTRO last year in 2024 from Dr. Murthy's group out of Tata Memorial with the BART study showing randomization between observation versus adjuvant therapy. And that's with modern radiation therapy to the cystectomy bed, as well as the pelvic lymph nodes using IMRT. That was actually the largest randomized study to date. It is awaiting basically updated, mature outcomes for its primary endpoint of disease-free survival. However, at early time point, as well as the acute and late toxicity, show that this is relatively safe. And that has been an ongoing concern from radiation oncologists, urologists, and medical oncologists that post-cystectomy, it is a really challenging scenario. The bladder is no longer present to displace some of the small bowel, which we know is very radiosensitive and is a high risk for toxicity. However, the BART study showed that overall, grade 3 plus events were relatively rare, actually around less than 2% in that cohort. And that should give us comfort that if we're using modern radiation with good quality, we can really offer a potential good option for many of these patients. And also, given that the current standard of care is adjuvant immunotherapy or nivolumab, we know some patients are not candidates for that, and many develop immune-related adverse events. We think to some of that, the rates of adjuvant immunotherapy, grade 3 toxicities being anywhere from 18 up to 50%, if you think of the Ambassador trial, quoting about a 51% overall grade 3 event toxicity profile. So we know immunotherapy is not benign. We give adjuvant immunotherapy, adjuvant nivolumab for many of these patients. However, if we're dealing with potentially just an isolated pelvic recurrence, well, in that case, why don't we offer cystectomy bed radiation and boost that area that's involved and potentially be able to observe the patient and hold immunotherapy in our back pocket down the line?